Thank you so much. It's my pleasure to be here. I was in Geneva several years ago working on a patient actually and had a great time for 2 weeks. And my friend Kevin Wilk called me and asked me to substitute for him. I was happy to do that. And I love Mario. Mario is fantastic. He's gotten our ICUS Society a couple of years ago, so we have a lot of fun together. But I'm going to talk to you a little bit about the post-op management of shoulder instability. But before I get there, I want to tell you about the city that I work in Houston, in the medical center. So this is actually the medical center. If I can, I think that's it. Okay. This is all the medical center. So there's 21 academic institutions, 14 hospitals, 34 million square feet, 20,000 physicians, 25 billion GDP, 25,000 babies delivered, 100,000 employees, and 10 million patient visits a year. So it's a big deal. This is the medical center. This is my building, and I'm up on the 22nd floor, and I have a beautiful view of downtown Houston. Houston's this huge, spread out, sprawling city. So I think our metropolitan area is 7 or 8 million people. We did have a rain event a few years ago. I don't know if you guys saw about this. It's called Harvey. This is a bayou. I live right over here, very close. This was about a half a mile from this bayou. So we had 52 inches of rain in 3 days. So I was way up in elevation. My house is at 48 feet, so I did just fine. But anyway, I have a really interesting place to work, and Houston has no state tax. You can get a house very cheaply, so a lot of professional athletes live in the Houston area. So probably 50% of my caseload are professional athletes. So I'm from Texas. I was born in West Texas, where they shoot all the cowboy movies out here. Then I moved to the big city of Lubbock, and then I moved to Houston in 1991. And here's Texas. It's a big state, but this part is not really that populated. So for me to drive from Houston to meet with my family is about a 10-hour drive. So it's a big place. So again, this has been talked about. I've been in Houston since '91, 35 years. I'm an old guy. Lived long enough to get in the Hall of Fame. I've been in private practice, corporate PT, hospital-owned sports medicine, and I currently work with UT physicians. I worked with the Astros, the Rockets, and NASA. It was so much fun to work with NASA. I would go there once a month, and they would line up the astronauts because they were older, athletes, and they trained very hard, so they had multiple injuries. And those guys know a lot about everything. So I got in the Hall of Fame, and they give you this professional wrestling trophy. And my son loved the trophy, so we were walking all through the streets of New Orleans with that, and he had a little celebration dance here. Pretty good at flossing. So we're going to review some cases, talk about scapular exercises, discuss some progressions and some techniques. That's what we use on our stiff shoulders. So what makes your shoulder stable? The reason the rotator cuff strengthening works in conservative management is it puts the ball into the socket. So you have this adhesion-cohesion concept so that the joint surfaces get really sticky. So if you don't have that ability, you don't have as good a result. So what about labral tears? What I'm going to do is show you a bunch of case studies of patients that I'm working on right now, and one of them has got an interesting problem. But if you have a complete slap lesion, that results in significant increase in anterior and inferior translation. If you have a partial slap tear, it doesn't. But this patient here actually had a 360-degree labral tear, football player. He had 9 anchors in his shoulder. Now, that's not something you would do with a baseball player, but it took us 4 to 5 months before we got full range of motion. So not all slap tears are the same. This is in my home on the weekend, so I'm a 7 days a week guy. No labrum. This is a patient that I'm working on right now. So Dr. Andrews, who's a very famous sports medicine, one of the founding members of sports medicine, called me and said, "Hey, I've got a good one for you here." And I said, "I operated on this guy, and I actually did conservative rehab on him, and he failed conservative rehab, but he did not have a labrum." So he had a congenital anomaly, and Dr. Andrews said I had to work really hard in this surgery. So what you have to do is you have to flip over the capsule and create a labrum and then tack it down. So it's a very unusual situation. So I did conservative rehab on him. He did actually very well, but the decision was made from a professional standpoint that probably he couldn't pass a physical. If we got him well, is at the midpoint of the season, so he elected to have surgery. So when you're dealing with professional athletes, sometimes the decisions are not all medical related. So he had 7 anchors in his shoulder. So I'm going to show you a couple of videos of his rehab. So this is him right here, this situation where you have no labrum, so you don't have anything for the capsule to be reattached to. Post-op recovery, after anterior stabilization procedures, we want approximately immediately 120, 45 of ER, 45 of IR, and manual assessment is really important. So we'll talk about that all throughout the talk today. So immediately post-op, we want to pain control, initiate passive range of motion, do hands-on stretching. We want to try to achieve full range of motion by the 8-week mark. This gentleman had a Latarjet, which will probably never gain full range of motion. So why is it so important to manually assess your range of motion? So every time the patients come in, unfortunately in our country, sometimes therapists are not as hands-on as they should be. And they'll give a patient a sheet of exercises, or they'll do the exercises and sit at their desk and do their notes and put ice on them at the end. So you have to put your hands on your patients to be a good shoulder therapist. The reason is you can assess and see if you need to push this individual or you need to go slow. And Scott Rodeo showed us that different people have different type of collagen. So different collagen fibrils. Some people have a high density of elastin, and some people have low density. So when you put your hands on your patient, you range them, take them through a range of motion, it helps you decide how much you need to push or how slow you should go. This is almost the same video as you showed, Ann, and this lady is a swimmer. So this individual, actually, I rehabbed for 6 months, because it takes 6 months to reverse a swimmer's posture, right? And she ended up failing and ended up having a slap repair. But you can see how much laxity she has. You can subflux her forward and backwards. So that individual probably post-operatively, if we were to stabilize her shoulder, we would go very slow with. This young man had a Bankart repair. Interesting story. He was in the clinic doing ACL rehab on his knee, and he was doing some upper body TRX stuff, and he dislocated his shoulder. So, you know, funny things happen. I was working on my side, and I looked over, and there was a group of people around the table, and they were trying to figure out how to reduce his shoulder. So I had to come over and help out. So here's our individual here that has had these 7 anchors, 4 in the back and 3 in the front. So he, on the top, here, he is at 10 days post-op. So we're taking him out to about 45 degrees of external rotation, and I love to use muscle energy techniques. So METs for me work better than mobilizations, especially early on. All I'm having him do is just lift his elbow into my thumb so that we can get a little bit of relaxation of the subscapularis and move a little bit into external rotation. So he's only getting 10 to 15 degrees of external rotation, but the worst thing you can do is put them in a sling and have them see you at 5 to 6 weeks post-op, which does happen, unfortunately, in some cases. So now here he is at 10 days post-op, 4 weeks post-op, and we're gaining range of motion. The thing I want to see with him is weekly progression. As long as we're making progress through the weeks, week on end, I think we're going to be okay. And obviously it's his livelihood, so the professional athletes are highly motivated and they have all day to do this. Another point I want to make is we talked about engaging the core and kinetic chain. Most of these guys, when they get done with me, they go work out with a strength and conditioning specialist. So I started 10 years ago having a strength and conditioning coach in my clinic. So that's been a really good thing. So they get done with their rehab with me, and I kick them across the carpet to our strength and conditioning coaches. And so we work together in the clinic on strength and conditioning. So maybe at the end of the rehab, they do 20% rehab and 80% strength and conditioning. But these guys are highly motivated, and they go do the core and leg work on their own. So the first early active exercise I like to do is a gravity eliminated sort of punch. And I think, like Ann said, this kind of helps to centralize the humeral head. We'll start this at 3 to 4 weeks post-op after a stabilization procedure. Remember, you haven't really involved the rotator cuff very much with this surgery, so there's no reason not to initiate activation of the rotator cuff. So again, we're moving up into a little bit more abduction now and getting external rotation. The other point to make is make sure you stretch them with the elbow to the side also. That way you can get all portions of the capsule. You get the middle glenohumeral ligament. Sometimes we get stuck stretching out at 45 to 90 degrees and they're stiff with the arm to the side. So he's progressing really well here. This is just another exercise I do, hands behind the head, elbows in and out. And we're not pushing at all, we're just moving through a range of motion. And you can manually assist them by pushing the elbow in at that point. So post-op instability precautions, you guys know this. You don't want to stretch too much into excessive ER and posterior stabilization. You don't want to do the opposite. So now here's another patient that's a week later than this football player. This is actually a soccer player. We don't use the term football because we get confused, and we get confused a lot in the US, so we use the word soccer. So this individual actually played here in Switzerland last year at a club just south of Zurich. Anyway, he dislocated his shoulder. He was playing in Cincinnati, and one of the doctors up there is a friend of mine. He lives in Houston, so he came to Houston, and he had a Bankart repair. So the difference is you can see the labrum here, the capsulolabral complex is torn off of the glenoid, posterior labrum, anterior labrum, glenoid, biceps tendon, and he was able to be reduced. And his range of motion went very quickly and very easily. So he's able to finish the season. Now he's at 5 weeks post-op after his repair, which was done by one of our physicians. And again, I've got him out at 90 degrees. We're not forcing range of motion, but we move them very quickly. I see them the first week post-op, and we start ranging them into elevation and external rotation. And after the 5 or 6 week mark, I really quit stretching him, because his motion was coming along on its own with his self-stretching. So he's one of these people that we want to go very slow with the range of motion. So opposite the NFL football player, his motion is coming along without any problem at all. And now he's at 7 weeks post-op. He's got near full range of motion. It's his right shoulder. So we use the rope and pulley. I think it's a good tool. All of our patients get one of these at home. And so he's doing very well. Now, why do we want to fire the rotator cuff? So in a perfectly normal individual, if you just fatigue the posterior cuff and you lift your arm up, you have 2.5 millimeters of superior migration of the humeral head. So as you increase the external rotators, you're able to centralize the humeral head, and patients do better. So that's one of our main focuses with those that have instability. So this is a tool that I use. This is just an external rotation with the TheraBand, which we really like. We do it at a 45-degree angle because that's right in line with the muscle action of the rotator cuff with the arm to the side. So with your arm to the side, the line of action of the posterior cuff is a 45-degree angle. So why shouldn't you exercise in line with that action, right? You know, you don't do quad strengthening in a diagonal. You exercise in line. So this is another tool developed by a PT in the US. It's called the UE Ranger. So it uses some of those early closed chain concepts that Ann talked about. So you can actually push into the wall. You can adjust this up and down. So it makes it really comfortable for them to start working with upper extremity flexion, and then we go in the scapular plane and do scaption with that. So we can start this pretty early. He's about 5 weeks at this point. The other thing we like to do is one of the exercises I stole from my friend Kevin Wilk called a hold and lift. So you hold one side up, you hold the normal side up, you do 10 reps on the one side, then you hold the other side and do 10 reps on the other side. So this is called a hold and lift, and he's actually doing very well. He's using 3 or 4 pounds. The other point to make is you can strengthen overhead. I used to not do any overhead strengthening because I thought it would injure my individuals, irritate them, but now we do the Snow Angels, and it's a very high EMG activity. Now this is a device that full disclosure, this is one that I've developed. It's called the mTrigger biofeedback. We love biofeedback. So I've got the biofeedback on his posterior cuff, and he's really working, this is a golfer, he's working really hard on eccentric control of the posterior cuff. So it's a 2-channel biofeedback, but we're just firing channel 1 right now. This is the amplifier. It sends all the information to the application via Bluetooth. So you can download this app on your phone or your iOS or Android device, and it works really well for us. And we have some games also, some gamification, and we can do a neuromuscular deficit test with this product. So you can test the normal and the involved, so it's really makes a big difference on our knee and shoulder population. The other thing to do is not forget about horizontal abduction and extension in the shoulder. So we get so used to stretching in the scapular plane, right? But athletes that are throwing athletes actually have to get back a little further. So this young man had a Bankart repair. He had full external rotation, but he couldn't throw a ball because he had no horizontal abduction. So I'm working hard for him, and I'll show you just a little pec minor release here in just a minute. And you see his elevation is impeded because he's banging into the acromion of his scapula. So just a little trick that everyone probably should learn, or if you haven't learned, you'll know now. Find the coracoid process, just go down to the pec minor tendon and follow it down under the pec major. Release that. It doesn't feel very good. But you'll immediately allow the scapula to drop back to the normal position. And some people say my first name should be Mo Paine. But you see we gain 20 to 30 degrees of elevation. So at least you're stretching the soft tissue structures. You're not just banging into bone. So now I want to talk a little bit about scapula. I agree completely with Ann. This is a very important structure with those that have instability. But it may be normal that some people have an altered position of the scapula. I pitched in college. I could throw really hard. My scapula was all over the place, but I never had any pathology. That's the difference between the shoulder and the knee. The knee, you had to do a Lockman exam, you've got a torn ACL, you pretty much know what to do. The shoulder is so dependent on dynamic forces that things are a little bit different. So this study looked at position of normal pitchers, and they show the decreased scapular upward rotation, or in other words, downward rotation may be normal. Probably because their capsule is a little bit looser, and they don't have that normal tension in the capsule. So that may be normal. So the biomechanics of the scapular motion, you've got upward, downward rotation, internal, external rotation, then you have anterior and posterior tipping. So we're really big into the scapula, and using those force couples is really important. So yes, this is what you want. You want upward rotation, posterior tilting, and external rotation so that you have this nice clearance and you're able to accept the humeral head into the glenoid. So the force couple are two forces that act in opposite directions to produce rotation about an axis. This is a scapular shirt that really works well, especially with high school kids that have bad posture. So we're really working hard to fire these the scapular muscles. Kibler has devoted a lot of his career to the scapula. He does a good job, but some of his things are hard to reproduce. This is the scapular dyskinesis. And he was trying to evaluate between examiners, and it was shown to be low reliability. But if you just do a yes or no, it increases to 0.57. It said, yes, he's got a scapular problem. In relation to that, a KT1000 that we use to measure an ACL tear is 0.92 ICC. So it's very subjective measuring the scapula. We really haven't found a really good way to objectify the scapula. But if you manually relocate the scapula and then have them lift their arm, I think that's one of the more reproducible tests. The pain goes away. This is what I do. This is an article I wrote in 2009 with Mike Voigt, or 2013 with Mike Voigt, IJSPT, on the scapula. It's got a lot of these exercises in there. I like to do a dynamic hold and also push with your fingertips into the wall. So at about 45 degrees or so, as you lower the weight down, you can see your scapula pop out. See my right scapula? I've got almost everything I talk about. Every pathology I talk about, I've got it. So this is my shoulder. So I'm pushing with my fingertips into the wall. This is what you don't want. You don't want downward rotation, anterior tipping, or internal rotation of the scapula. So you want to strengthen the serratus anterior and the upper trapezius and the lower trapezius, especially to change that posture. So here's a young lady we showed with the swimmer that's got poor scapular stability on both sides, but if you look at her left shoulder, she comes down to that 45-degree angle. She's got more probably downward rotation and anterior tipping with this left scapula. So we worked really hard with her to reverse that. Here's some of the scapular control exercises that we like to do. This one is my favorite one. If you have one exercise you want to do for the scapula, this is something we kind of put together. It's called a Swiss ball robbery. So your elbows go down to the back pockets and you get into full external rotation so you can produce that upward tilting position of the scapula. This works really good for your high school athletes because they tend to have really poor posterior chain, right? Yeah, a picture of me in my yearbook in high school and I'm sitting in the stands like this, you know. So if you put them on the Swiss ball, they have to fire their posterior chain and work the lower trap. So that's a really good exercise to do. Ben Kibler described this with Tim Muehl in 2008 as the robbery, and we just put people on a Swiss ball to do it. So here's our EMG device, and we're testing to see how much of this really works. So this is really cool to be able to identify and prove to yourself what muscles are working with the different activities. So this is a Swiss ball robbery. We have good results with that. This is the dynamic hug, which I like a lot, which is really good for the serratus anterior. These are some more exercises. This is a push-up with a plus with resistance on the normal side. So you have to tell them to stay in that fully protracted position. Again, we're firing the posterior cuff, as Ann described, and the serratus anterior. And we'll just finish up here in just a minute. And this is another really good exercise, the wall slide. The serratus above 90 degrees has got really high EMG activity. You can see this is channel 2 with the serratus anterior. And then when you add the TheraBand to that, it makes it even more difficult. So our young man is about fatigued here. Just some other exercises here that we do in the clinic. This is my best test. I do a manual resisted protraction, retraction, and if they have a painful arc and the pain goes away after I get a muscle pump, I know I need to focus on the scapula musculature. Swiss ball robbery there. Seated rows are really good. We do a single arm seated row, which is excellent. Stability exercises, just to finish up here. We use the Otis device as sort of an end stage. This young lady had a slap repair. It's got 2 ball bearings in this device. Here's the conservative rehab before his surgery that we showed you earlier. And he was able to get to these apprehensive positions no problem, but he still had a little discomfort in his posterior cuff. So he really couldn't function, although he was stable. And the article just came out, this past year that's showing that high school athletes can actually go back to like 85%. Here's the ball bearings, you can kind of see them, with conservative management. The rebounder we use quite a bit. This is another end-stage plyometric exercise, and you can see that he was able to achieve these positions without too much difficulty. Deceleration, I threw this in there a few minutes ago. This is just a takeoff on the decel. We use this with our pitchers and throw a ball drop in with it, and this is very taxing. This guy's elite professional MLB pitcher, so he's very strong. I don't think you can do that initially, but that's just another trick. Closed chain I like, but I'm not as crazy about it as some others might be. It depends on how you function. The Super 6 is another really cool exercise. I don't have time to show that, but if you go to mTrigger.com, which is our biofeedback thing, I'll have this online for you. The MR system is another cool device that we use. And then with weightlifting, this is a modified bench press here. Our country has the fattest people in the world. My wife's Chinese. Her parents moved over from China, And it was like they were in the zoo watching people walk around when they first came. So we've got a real problem with that. But with weightlifting, you want to keep the elbows from going more than 15 degrees behind your body. And if you do pinch press, keep your arms at 45 degrees. So conclusion, gradually restore motion by 8 weeks. Got to be hands-on, strengthen the scapula, fire the rotator cuff, then add stabilization drills. Education is key. So I show, all of our patients get pictures and post-op report from our surgeons, and we go through that with our patients. I think the more they know, the more they will buy into your program. Thanks for your attention.
Thank you very much, Russ. We have time for questions from the audience. Wir haben Zeit für eine Frage aus dem Publikum. Sind Fragen aus dem Publikum? Wenn nicht, haben wir eine Frage von Slido. So we have a questions from Slido. It was like it very much. What is a neuromuscular control test?
It's a neuromuscular deficit control test as part of the device, the mTrigger device that I've developed with my friend Brian Pryor. He owns Light Cure Laser. Basically what it is a test that's on the app. You just hit the button, and let's say you want to test the right knee versus the left knee. If you've had a right ACL, you put the electrodes on the quad on both knees, you start the test, you do 3 contractions on one side, 3 contractions on the other side, and it automatically calculates a % deficit of neuromuscular deficit. So what we're trying to do is find out, because they're EMG devices, but they're mostly used for research. So this is a clinical device that you can have in the clinic. Now we're trying to correlate that neuromuscular deficit to strength deficits and see if there's a crossover. Some people, it takes them a year to get their quadriceps isokinetic strength back, and some never get it. Well, do they still have a neuromuscular deficit? So now we have a tool to be able to measure that.
Thank you very much. Thank you.
Thank you.